I would say, if you want to keep your erections for a long time, take care of yourself. And that usually works. It really works well because men are very motivated. Yes.
Hello and welcome back to our favorite show, DocTalk. I'm Lissa Klein. I'm here with Dr. Janet Choi, Progyny's Chief Medical Officer, and a very special guest for Men's Health Month for June, Dr. Michael Werner of Maze Laboratories. We are talking about Men's Health Month, which is really exciting. So it's June. Plan your vacations, get out your summer clothes, and let's talk men's health. And whether you're a male watching or someone who cares about a male watching, we know that sometimes men aren't always the first to prioritize their own health. We know that we talk to some males and their female partners, and they haven't been to a doctor since their pediatrician. And the CDC found that men are 25% less likely than women to have visited a doctor in the past year. Younger adult males especially are susceptible to this, and so that's why DocTalk matters. That's why Men's Health Month matters. And today, as I said, we're honored to be joined by Dr. Michael Werner, who's a pioneer in the male fertility space. So we're going to learn a lot. He's also the founder and medical director, as I said, of Maze Sexual and Reproductive Health. He will break down male factor infertility and talk about a revolutionary, really exciting new technique his laboratory uses to find and save sperm for men who are otherwise have sort of bad diagnoses. So let's jump right in. You ready?
Yeah.
Let's do it. Let's talk. Okay, so Dr. Werner, in your experience, what brings men in to see you? And do you find that they're waiting extended times to actually see a doctor, or is it typically pretty quick?
So again, my practice is two pieces. I do male infertility and male and actually female sexual dysfunction. So male infertility, the field has changed dramatically since I came. It's been almost exactly 30 years. And it used to be literally when I started that the woman would have her entire evaluation and everything would be fine, including sometimes the laparoscopy. And the men would say, I'm not getting a semen analysis, and then everything would be fine. And then they come in and there were no sperm. So that has flipped. Both the OBGYNs are not putting up with it and the women are not putting up with it. And so it usually is that the first step is a semen analysis, and that happens very quickly.
And then they're referred to you if something is abnormal,
right. So
typically.
My lab is very sophisticated at doing semen analyses, and we also do sperm banking, and then we do this ESSM. So a lot of the times they will come to me for a semen analysis, and if it's a screen and it's normal, then that's my involvement at that point.
Yep. When care is sort of delayed, if you're seeing that, or when you used to see that, what do you think is the reason for that? What's driving that?
Many of things have changed, but also the demographics of what age the women are when they're trying to conceive has changed dramatically, and they're much higher now. So our window of really is compressed in terms of really their fertility window. So we really want to get things done quickly.
Yeah, love that.
And I'll just add, by the way, and
Please.
Thankfully there has been a downward trend. I think more male partners are more amenable to getting testing right up front. But we still see, heterosexual couples come in, or sometimes just the female partner, because she'll say, my male partner said, first get myself tested and evaluated before he's going to do anything, which is really frustrating because, I think time becomes really essential, especially if you're dealing with normally aging ovaries and eggs and infertility. So getting both the male partner and the female partner in the door and getting tested in parallel, like you suggested, is a wonderful idea.
Yeah, makes sense, especially as you mentioned with that advanced maternal age. So the age of the female partner is sort of a timer that has to be addressed quickly. And so on that note, curious about male factor infertility. A lot of times infertility or fertility is attributed to the female partner. Again, we're talking about heterosexual couples here. And so my question for you is male factor infertility as common, or how common is it?
So the breakdown traditionally is it's 40% male, 40% female, 20% both.
Yeah.
So, and again, this procedure, which I think you want to focus on, the ESSM, is really dealing with men who are extreme in terms of their azospermic, so azo means none, or cryptospermic means they have very, very, very few.
Oh, I've not heard that
Yeah,
term before.
crypto, I love that. Crypto is like in the crypt, they're hidden.
Yeah.
So anything crypto, is hidden. So it means that when they do a semen analysis, they find some, sometimes some, not others. Those are the ones that torture the reproductive endocrinologists and the IVF centers because they never know whether they're going to find something or not. And but with the cryptospermic patients, we're finding sperm 94% of the time. And when I say we find them, the ESSM means that we can also freeze them as well. So it stands for extended sperm search and microfreeze. So we're actually we're finding them, but it's not just a diagnostic procedure. We're actually taking them, putting them on these little teeny wells, freezing them in a manner just similar to where they freeze eggs, so that they have almost a 90% thaw survival rate.
That's great. And so that would eventually be used with ICSI, which is intracytoplasmic
Exactly.
sperm.
Right. And sometimes we can do it, if we're in the New York area, we will actually do it fresh, and then we'll send it over to them in incubators, so they only have to be frozen.
Yeah, that's exciting.
Does that require surgery, or can the man just give you an ejaculate?
Right. So the ESSM, when I'm talking about that, that's just from the ejaculate. So we started the technology came from Israel in 2000, and we started doing it in 2019. We've done about 880 of them, and on 580 different men, and we're running almost 40% of men who have no sperm in the ejaculate that would usually need to have surgery to try to extract the sperm, not always successful, which is invasive and actually much more expensive for you both. And we're finding sperm in almost 40% of them, that usable sperm.
Can you actually explain to me, because I've seen this before when I see male patients who come in bringing records and they're repeatedly azospermic, and then suddenly they go and get their sperm tested with you or another lab, and they start to find maybe not millions of sperm, but a few twitching. So why is there that kind of disparity between andrology labs?
Yeah, so the analogy I give, it would be in my lab too. If you do a straightforward, the analogy I give is let's say you have a lake and it's teeming with fish, and you put a scooper in, you're going to get a lot of fish, and depending on how teeming it is, that's how many fish there are, right? If there are 9 fish in the lake, and you put a big scooper in, the chances that you're going to get anything are like 1 divided by the volume of the lake, right? But if we drain the entire lake and spend all day looking in the muck, like looking at every part of the muck, we're going to find those 9 sperm.
Yeah.
And then the nice thing is we can take them, micromanipulate them just like you would do with an ICSI, take the sperm ejector, and put them on these wells, and then they freeze beautifully, and then it's very easy to find. It's like, as my andrologist will say, it's like putting a little bow on them. It's like you put them in the dish, and then you put them right in the bow, you know.
So that analogy is that actually with the lake is very helpful. So could you also just explain to the audience and to me also, so standard SA takes how long for an andrologist versus doing an ESSM?
Right, so a standard...
SA is a semen analysis.
Yeah, sorry.
So a standard semen analysis, I mean, again, there's a lot of pieces, but in terms of you're traditionally taking a drop of the specimen, and then you're looking at it, right? So if you don't find anything, then traditionally you'll spin it down and look at part of the pellet. So, and then there's all antibodies. So the semen analysis can take a while, but the searching is really 1 drop, 2 drops, maybe 3 or 4 slides. So that searching is very short. You're just counting the. When we do the ESSM, first of all, we have to drain the lake. So there's that whole process, and then we have to plate it. There's that whole process, and then we spend all day looking at it. So it's about an 8-hour process.
Versus maybe like a 30-minute process for a sperm analysis.
Correct. Which is why it makes sense. Why it's much higher.
Especially to avoid, as you said, a pretty invasive procedure, which is something usually called a TESI or a MESA. Testicular sperm extraction.
So those are a little bit different. A TESI is the classic is a micro TESI. So you're looking under the microscope, you bivalve the testis, and you're looking at all these different places, and then you're looking to find the sperm. Obviously, that's invasive. It requires anesthesia. It requires the hospital. The recovery is really miserable. I mean, it's worth it if you, I mean, I'm not saying you shouldn't do it, but you also are damaging the testes to a certain extent. You could say, well, it doesn't matter if you damage the testes because they're only there to make sperm, but they're not there only to make sperm. They make testosterone also.
So we heard about the ESSM, which is really interesting, and about a standard semen analysis, which I also like. Can we talk a little bit about like men's health in general, ways to optimize like spermatogenesis, right? What can people do in addition to seeing a doctor like you, in addition to seeing a reproductive endocrinologist? What are some things that are general wellness, like lifestyle modifications that can happen for just overall men's health?
Right. So in general, it's the same thing for sexual medicine. The same, anything that's good for you is good for your sperm, is good for your heart, is good for your complexion, is good for, basically common sense. But I do really ask the men to be purists when they're trying to conceive for 90 days before, right? So you can't go on a bender and then 3 days before, it's like, because everything that you did in the 90 days before is going to affect it. So I really do encourage the men, no marijuana, no drinking, definitely no smoking, but then reasonable stuff. I'm not a mega vitamin person. They've never proven that mega vitamins really work for anything. We do have some men who have a lot of, that we put on antioxidants. I'm not a big supplement boy, but there is, proof that the antioxidants can help with the sperm and their effectiveness. So really, it's common sense. Anything
like healthy diet, sleep, and don't drink and smoke.
What about vaping? I know that it's kind of a newer substance, but
avoid everything you can. Would I prefer vaping to cigarette smoking? Yes, I would, because in theory, you're not getting as many chemicals. It's a pure way of getting your nicotine. But if the better you can be, the better.
I like pointing out that while there are things that you can do to optimize your health, it's also not something you should blame yourself for, right? Having no sperm,
You can blame your mother and your father.
Actually, I want to geek out here for a second. Back to the SSM. Is that actually potentially a usable tool for someone with Klinefelters, for instance?
Yes. So let's go back to azospermia, which is a fascinating and the most complicated part of male infertility.
And azospermia is no sperm in
the
ejaculate.
Sperm in the ejaculate.
Yeah.
Okay,
not even one twitching.
Not even one twitching. Because then we move to cryptospermic, and then it's almost moronic not to do an ESSM, to be honest.
Right.
So when you have men, this is the most complicated part of male infertility and the most interesting. So the question is the problem that they're not making any or many sperm, or are they making it and they can't get it out?
It's not in the ejaculate.
Right, right. So and if they're can't get it out, why can't they get it out? So it could be that they are blocked. They could be missing the tubes. They could have had a vasectomy and not tell us, which has happened. They sometimes don't tell their wives. Men can be creeps. It's funny because I spend my life working with men and I like women a lot better. But what can I say? And I have 4 boys. Maze stands for Matthew, Adam, Zach, and Evan. But anyway, so I could go the different scenarios I've had. But basically you can be blocked or have problems with ejaculation. Or you can be not making them. So we have to figure that out. A lot of that is based on the history and the exam. So if a man has great sized testes and normal hormones, then you have to be very suspicious that they're blocked. So we've had men that could be blocked because it's genetic. They can be blocked because they had hernia repairs on both sides and the doctor blocked both of their vas deferens. They could have a big cyst sitting in their prostate and none of the sperm are getting out. There's a whole litany. Those are heaven. They come in and they have a zero, right? And they're like, oh, I'm never going to be a father, which actually my heart goes out. I'm not.
Of course.
And then I examine them. It's like great sized testes, missing the tubes. God gave you a vasectomy. I will find sperm. And it's like, and they go, I had one guy come in, he had found this out when he was 25, and then he just thought he would never be a father. He came in at 45. He said, I finally have some money. He was from England. He said, I'm just going to give this one last chance. And he walked in, and it's like within 4 minutes, I'm telling him, I think we have a 98% chance of finding sperm. I love when they cry. I like making people cry. It's like happy cries are fun. Yeah, and it's really fun. So azospermia is, we divided it into that, but it's pretty common.
Yeah. And so if they're not making sperm, if it's not a blockage, if they're not making sperm, what are
so that's called non-obstructive because they're not blocked. So the question then becomes a couple questions: can we get them to make sperm? And also, are they making some very low levels of sperm, but we're not seeing it when we do a conventional semen analysis, or we're not even seeing it when we do an ESSM? That's a very counterintuitive problem. You would think, well, if you're making them, why aren't they coming out when he ejaculates? So the analogy, having little children at one point, I think of the testes as the castle in Beauty and the Beast, right? So it has this huge roof. If it drizzles, a little bit, nothing's going to come out of those leaders, right? Because it just stays there.
Yep.
If it pours, you're going to see it. That's what's supposed to happen.
Yep.
So we know that some men will have very low levels of production, and the testes are not what we call homogeneous. So they have a section here, a section there, and so there'll be nothing in the ejaculate. But when we do that open tessie, then we'll find something. Or when we spend all day, there's so few you wouldn't see it on a conventional semen analysis, but you'll see it when you do the ESSM.
That's fascinating. When you were seeing patients, you are an REI, so reproductive endocrinologist.
She's a good one, by the way.
It's a good one.
We did work together.
So did we, and we do again.
Okay.
So when you, Dr. Choi, were seeing patients in clinical practice, you would be usually seeing a couple, a heterosexual couple in this example that I'm giving. When would you refer your patients to a urologist?
Lots. I mean, so anytime if I had a gentleman who would, was doing his first sperm analysis, if it was mildly abnormal, I would always recommend, because you don't want to just base your judgment on one sperm analysis. It could just be one bad, assay. I would have them repeat it. And in between, because I know that time is of the essence for a lot of these couples who are struggling with infertility, I would say it may not be a bad idea, just like your wife or your female partner is seeing me, a gynecologist, reproductive endocrinologist, for you to potentially set up an appointment with a reproductive urologist, because heaven forbid, if the second sperm analysis is also abnormal, that way you have the right specialist kind of doing their full-on evaluation of you, seeing if there's anything that they can recommend to improve your side of the equation to optimize the chances of the two of you having a baby efficiently.
And not only is it important for reproduction and sexual health, as we've talked about, but these can also be indications of something else, correct? That's wrong or abnormal in a person.
So when I started my practice, sometimes we would find out that the men had Klinefelter syndrome, which is basically an extra X. Now most of the time we know prenatally, but at that point they would come in, they had no sperm or very few sperm in the ejaculate, and then we would find out that they were Klinefelters, and those patients almost always have a low testosterone. So once we're finished with fertility, if they're symptomatic, then we would put them on testosterone.
Yep. Got it. So it's important for overall health as well to have these types of things evaluated.
But can I also just call out, this is a reason why male patients need to, if they have fertility and family building forefront of their mind, to make sure they're seeing a urologist, reproductive urologist, who specializes in the area of fertility support. Because what Dr. Werner just said, timeline-wise, is really important. After somebody is done with their family forming, and then if they still need testosterone supplementation, that's when you start it. You don't want to give somebody willy-nilly testosterone without asking their fertility and family building needs, because all too often we would sometimes see patients, and my colleagues still do, where the gentleman comes in the door, sometimes it doesn't even mention that he's on testosterone because he doesn't think of it as a medication per se, and then lo and behold we have an azoospermic specimen, so no sperm on sperm analysis, or really low sperm counts, and then on further questioning he divulges, or he was like, oh yeah, I saw this person who put me on testosterone, not realizing that it was kind of a contraceptive. Right?
So I have one of the other things, and that's part of Progyny also, is so I have a sperm bank. So what we'll do in those situations, if a man comes in, he's very clinical, it really is a low testosterone. It's ruining his life. No libido. Now imagine you're 19, you have no libido, you have no energy. I used to try to temporize and put them on Clomid and HCG, things to make them make their own testosterone, but they never felt as good as testosterone. So I really push them to bank their sperm, and then I treat them. It is reversible 99.9% of the time, but some men really need that testosterone. But it is remarkable to me how many people are about to start their families and a doctor puts them on testosterone and it shuts down.
Right. Curious about those emotional responses, but also how stigma and the lack of knowledge and conversation around this can impact people getting to see someone like you.
I think people are getting more and more mature.
Yeah.
I mean, both
good.
Literally, and I think that it's seen as more medical. I mean, for men who, one of the treatments for men with really poor semen analysis, or even if they're zero and then we find some, is that their wives their partners, if again heterosexual patients, have to go through an IVF. So it's my bad sperm that's making my wife go through an IVF. But you're a team. And so, if one of you developed a bad disease, the goal, you take care of each other. So it's not, there are worse things than an IVF, I mean, I would put my wife through an IVF so that we would have children, and so there is a guilty piece, but it can be moderated, and when you think about, you put how many people through how many cycles. It's not the most fun to go through an IVF cycle, but if you want children, that's much more game-changing than the process of an IVF.
Yeah.
Everything is risk versus benefits.
Yep, and IVF is well tolerated by most people, like you're saying, and overwhelmingly safe. And for people who have a benefit like Progyny, it's typically covered. And so if that is the next best step for you, a lot of resources to help people with doing it. Right. So what message do you wish more men heard during Men's Health Month?
So we're focusing in on infertility?
Yeah, I think in general, but
yes.
Infertility.
Well, look, men don't take great care of themselves.
Yeah.
In fact, what's interesting is I was once approached by the county, the public health people. They said the only thing that gets men into a doctor is erection issues.
Shocking.
They'll be there the next day, so it's like, so they wanted to figure out how, and the truth is I use the erection issues as a way into their health, because that's a very clear barometer, even more than fertility is, of their overall health, right? Yeah. Whatever's good for your heart is definitely what's good for your penis, and vice versa. Mm-hmm. So, we're looking at cholesterol, we're looking at blood pressure, we're looking at diabetes, that kind of stuff. So I would say, if you want to keep your erections for a long time, take care of yourself, and that usually works. It really works well, because men are very motivated. Yes. So you hit them where it hurts. Yeah.
Take care of yourself. Yeah, I like that.
Take care of yourself so that your penis works.
Right. That's a really good message, I think, for Men's Health.
It's very effective.
Yes, one that resonates. We appreciate you being here, because I think starting this, having this conversation certainly will help people understand their options, and just talking about this, I think, is always a good thing. Yeah. So thank you for joining.
My pleasure.
Much. And thank you for being a part of our network. We love that. And so if you have questions for us that you want us to talk about, please drop them in the chat. We love hearing from you and love sort of creating content that is impactful for you. Happy Men's Health Month. Please take care of yourself. Good diet, no smoking, no drinking, no marijuana, and sleep.
A lot of sex with the right person.
A lot of sex with the right person, yes. Thank you so much for joining us, as always. We'll see you soon.
Thanks.
Bye.